Zoom, and I think we have the Oshkosh Senior Center on here as well. So welcome to all of you that are joining us from Oshkosh as a group under that Zoom. So we will get started here in just a minute. I think we still have one more minute before 1 o'clock, and then to be respectful of time, we'll get started right at 1. Even if we have a few stragglers joining us. We are recording the session, so if you miss something, if something happens and you need to step away, we will send you that recording. All right, well, thank you to everyone who's joined. Welcome, and we really appreciate you being here today. My name is Kate, and I am joined by several of our committee members here for the Brown County Dementia Friendly Community Coalition. You probably see Sherry over here, Heather over here. We have Laura. I know I saw Casey join. So some of us are on Zoom and some of us are here in person. If you are not familiar with the Brown County Dementia Friendly Community Coalition, we are an active coalition that's made up of several different subcommittees that work really hard to make Brown County a dementia-friendly place to live. And one of those subcommittees is our education subcommittee. And so we are a group of people, many of us work for agencies that provide education or provide different services related to dementia, but we come together and we say, what are the gaps in our community? Where do we need additional education? And research is a big one. Many of us have delivered education programs or met with constituents who have asked us, why do people who have diabetes have a higher risk of dementia? And we know that statistic, but we don't always know how to answer that question. And so we are really, really excited to have Dr. Gilda Ennis here today. We reached out to her with that question to say, can you talk about this a little bit more? And so Dr. Ennis is a scientist at the Alzheimer's Disease Research Center, which is at the UW-Madison School of Medicine and Public Health. And she's always had a passion for studying factors that influence our cognition in older adulthood. She has been involved in research at North Carolina State University, where she received her PhD, and Georgia Tech. She has participated in the Alzheimer's Association International Conference with poster presentations and is a grant recipient of Alzheimer's Association research funding to look at that longitudinal link between insulin resistance and Alzheimer's disease. So we are so grateful that she accepted our invitation today to speak with us about her research. And I'm excited about what we're going to learn together today and very honored to have her here with us. So just one housekeeping item, she will take some pauses during the presentation for questions. We will be monitoring the chat. And so if you want to put a question in the chat, you are certainly welcome to do that so you don't forget it. If you would like to unmute yourself and ask your question live, that is okay too. So either one of those options work for us, whatever's most comfortable for you. So with that, I will turn it over to Dr. Ennis and look forward to all we're going to learn together.
Well, thank you very much for that introduction. That was very kind. I hope you can hear me well. Please let me know if I fade out. I've had some difficulties with my mic in the past. So I'm very pleased to be here with you today. It's a beautiful day today, so I encourage you to get out and walk around in this beautiful weather that we're having after we're done with this presentation. So yes, I'm going to talk to you a bit about what we understand about insulin resistance, type 2 diabetes, and brain health And I plan to pause a little bit throughout this presentation to give you an opportunity to ask questions. But I mean, before I get started too, I really do want to thank everybody in the Alzheimer's Association for providing, I received funding from them to do some of the research looking at the relationship between insulin resistance and biomarkers of Alzheimer's disease. I work in the Bendlin Lab, and so I receive support through that lab to do my research too. And then we have participants that come and donate their time to the research at the Wisconsin Alzheimer's Disease Research Center. So there are many, many people that are involved to make the research that I'm going to present, and really all research, possible. So I'm going to first start off by defining the two major types of dementia: Alzheimer's disease and vascular dementia. And then delve into some of the research regarding the relationship of insulin resistance and type 2 diabetes to cognitive function and dementia, and also Alzheimer's disease pathology and biomarkers of Alzheimer's disease pathology. And then just discuss what diabetics can do to maintain a healthy brain. All right, so first of all, some of this you may be very well familiar with, but I like to just review briefly what is dementia. And so, it's not a specific disease. It's just a general term for describing problems in thinking and memory that interfere with the ability to function at work or do usual daily activities. So if you occasionally misplace your car keys or struggle to find a word, but then you remember it later, or you forget the name of an acquaintance, these are all normal aging-related memory changes, and they really shouldn't be a cause for worry. Some signs and symptoms of dementia are having trouble with things like, following a familiar recipe, keeping track of monthly bills, having trouble driving to a familiar location, having trouble following or joining in on a conversation. So generally just having trouble with the usual daily activities. So what causes these dementia symptoms? What do we know about that? So it is due to the degeneration of neurons. And so as the nerve cells degenerate, some of these symptoms can appear in people. And of course, nerve cell degeneration causes the brain to shrink. And the word that's used for that is atrophy. And we can see atrophy on CT or MRI scans. And the images here are from an MRI scan. And it compares someone who is cognitively normal here with someone who has mild cognitive impairment to someone who has dementia due to Alzheimer's disease. And so I think you could probably, just look at this and see the vast difference in these brains, but just pointing out some of the things that we pay attention to. In the middle here, this black space, this is called a ventricle, and cerebral spinal fluid would be located here. As the brain shrinks, that area gets larger. And so you can see it's much larger in the person with mild cognitive impairment and in the person with dementia due to Alzheimer's disease. Another area that we pay attention to is this area here. It's sort of a light gray color, and it's on both sides of the brain. This area is really important for memory. It's called the hippocampus. That's the name of that structure. And it shrinks in Alzheimer's disease. So you can see that black space there. That means this area has shrunken. And then it's much, much smaller here in this person with dementia due to Alzheimer's disease. So it's those kinds of changes that, precipitate the symptoms of dementia. And there's several different types of dementia. We do focus, of course, on Alzheimer's disease a lot because it's a major cause of dementia or type of dementia. But there are others. There's vascular dementia, frontotemporal dementia, dementia due to Lewy bodies. And at autopsy, neuropathologists can find mixes of these. So something called mixed pathologies, where an individual may have Alzheimer's, signs of Alzheimer's disease, plus signs of vascular disease, and maybe Lewy bodies, so dementia due to Lewy bodies. So that is a presentation that's also somewhat common. But what is Alzheimer's disease? It is characterized by amyloid plaques and neurofibrillary tangles of tau protein in the brain. And so in this little drawing here of the normal brain, we have healthy neurons, all right? These purple structures are the neurons. But in the Alzheimer's brain, there are an accumulation of amyloid plaques, and they are found outside of the nerve cells. And then within the nerve cells, there are these structures called neurofibrillary tangles, made up of tau protein. Of course, these are very abnormal and are thought to cause nerve cell degeneration. So dementia due to Alzheimer's disease is only definitively diagnosed by linking clinical symptoms prior to death to the presence of amyloid plaques and tau tangles in the brain at autopsy. And so it's very important that these two are linked. So there needs to be an identification of dementia symptoms prior to death, and then that would be linked to this pathology in the brain at autopsy to come up with a definitive diagnosis of Alzheimer's. But we do have a way now, and have had this method for a bit, for observing Alzheimer's disease in the brain of a living person. And so this can be done with a special brain scan called positron emission tomography, or PET. So we have amyloid PET, which detects amyloid plaques, and tau PET, which detects neurofibrillary tangles. So amyloid PET is, some scans from an amyloid PET is shown here. And in Alzheimer's disease, you can see these red areas, and that's where the amyloid is in this person's brain. Whereas in the person without Alzheimer's, you don't see those red areas. Okay. Now, the plaques, these abnormal plaques and tau tangles, are present in the brain many years prior to dementia symptoms. All right, so this is known as the preclinical phase of the disease. So the phase where there aren't any symptoms, and it lasts, a very long time, 10 to 20 years before symptoms develop in mild cognitive impairment. So there's this transition to mild cognitive impairment, and then a transition to dementia. And so what this graph is just showing you on this bottom axis, the x-axis is time, the y-axis is cognitive functioning, and then it's showing you the progression over time of cognitive functioning in somebody who has Alzheimer's disease. So obviously it's quite a bit of a decline. But in normal aging, we see a little bit of a decline, but not as much. The preclinical phase is of interest right now. Well, it's been of interest, but for clinical trials, because it's thought that this is the time period when interventions might have the greatest impact. And so, there's the thought that perhaps if we could remove some of the amyloid and tau from the brain during this phase, that might slow or prevent the onset of MCI and dementia. We don't know that yet. All right, so I've been talking about Alzheimer's disease, but another kind of dementia is a vascular kind. So vascular cognitive impairment and dementia, and it's attributed to vascular disease in the brain. The brain, of course, unsurprisingly, is filled with lots of blood vessels, and if there's damage to these vessels, that can place somebody at risk for vascular cognitive impairment and dementia. So this can happen after somebody has developed a stroke. And so this is a scan showing you this little white area here is a lesion, which is known as an infarct. And this is what caused a stroke in this person. A stroke happens when blood flow is interrupted due to a blood vessel clot or a ruptured blood vessel. This, of course, is quite serious because that prevents the delivery of oxygen and nutrients to the brain. And if not treated immediately, the brain cells will die. The most common type of stroke is due to blocked blood vessels. So if someone experiences a stroke and then they develop cognitive symptoms afterwards, and those cognitive symptoms persist, then we would say that the individual has vascular cognitive impairment. But a stroke is one cause. An individual doesn't have to experience a stroke in order to have vascular cognitive impairment and dementia. There are other signs of vascular disease in the brain that are related to this type of dementia. And that would be a small infarct that's not associated with a stroke, and these things called white matter hyperintensities. All right, so you see this white stuff that's in the brain. This is damaged white matter. White matter helps to convey nerve impulses in the brain. And so when it's damaged like this, those impulses don't get conveyed as well as they should. So these things together, of course, influence cognitive functioning. And I should note that type 2 diabetes is certainly something that's associated with these kinds of changes in the brain. All right, so I think I will stop just for a second now if you have some questions about what I've presented thus far. Perhaps some of it's a review.
Does anyone here live have any questions? No? I don't see any in the chat. I'm just going to give a second. Does anybody want to unmute yourself if you have a question? I did have one question actually, as it related to the image that you showed of a healthy brain, a person who has mild cognitive impairment, and then a person who has advanced dementia.
Mm-hmm.
So I noticed there was this really big difference, right, between the cognitively normal brain and the person with MCI. And there wasn't nearly as much of a difference between the image from the MCI to the advanced dementia in my perspective. But the symptoms from normal to MCI seem so subtle, whereas the symptoms from MCI to advanced dementia seem so severe. So can you explain a little about why that might be?
Well, MCI, this is one example. I think you've made an excellent observation. I agree with you. This brain looks very similar to the AD brain, although one thing that is a little bit different between the two, you see how these areas are much wider in the AD brain. These are known as sulci. They're not quite as wide here in the MCI brain. Do you see that?
Yes. Mm-hmm.
So that is a big difference between the two.
Sure.
However, I agree with you. They do look very similar. And, it's just one example. It's probably from somebody. I suspect this individual with MCI is really probably pretty close to developing dementia.
Okay. I wasn't sure, sometimes we hear about people being able to compensate really well for cell death in the beginning of their disease process. And so I wasn't sure if that was part of it, if, even those minor changes maybe were where we're seeing less ability to compensate for the cell death that has occurred.
Yeah, these are all really great questions. And so, yes, there is some resilience and there is cognitive reserve. And this is such an active area of research. So yeah, there's evidence for people being able to compensate for quite some time, with even pathology that's present in their brain.
Sure. Thank you so much.
Mhm.
All right, I don't see any other questions coming in the chat, so I think we can continue on then.
All right, so now I want to talk about the relationship of insulin resistance and type 2 diabetes to cognitive function and dementia. But before I do that, I thought I would talk just a little bit about insulin and insulin resistance. And so insulin is a hormone that's secreted by the pancreas, a variety of functions in the body and in the brain. All right, so it's really an important hormone in the brain. But in the body, it helps glucose enter cells in the liver, muscle, and fat. And so what this cartoon or figure is showing you is a cell. So this is the cell membrane. And then on the cell membrane, there are these gateways or little sites, like little doorways, and insulin pops into this little area here. And when it does that, it allows for glucose to enter the cell. All right, so this is what normally happens in liver, muscle, and fat. It allows glucose from the bloodstream to come into the cell so that there's normal glucose metabolism. But in insulin resistance, this whole process is disrupted. And so cells become insulin resistant when they become less sensitive to the action of insulin. So this degree of insensitivity or resistance I'm representing with these dashed black lines. So the insulin is available, but it's just not able to have good action on the cell because the cell is resistant to its action. And as a consequence, glucose, it is unable to go into the cell. I mean, maybe, a few bits of glucose are able to get in, but this, it's a serious problem. So it causes an increase in glucose in the bloodstream. But the body is good at trying to compensate with these problems, all right? And so non-diabetic individuals that have insulin resistance produce more insulin, and that helps them to compensate for the insulin resistance. So there are these little orange triangles, there's more of them, more insulin, and that helps to overcome a little bit of the insulin resistance. So that's why there's only one black line here. And glucose is able to enter into the cell. So we would call this prediabetes. It's not necessarily normal, but people are able to maintain glucose levels below the diabetic threshold. There's mild metabolic dysfunction. But unfortunately, what happens in diabetes is that the pancreas is no longer able to produce enough insulin to compensate for insulin resistance. All right, so there's a reduction in the amount of insulin needed to compensate for insulin resistance. And so we're back to this situation here where there's lots of glucose building up in the bloodstream. And there's serious metabolic dysfunction. There are a lot of consequences to diabetes. One is there's impacts on vascular health. And so, I'd already mentioned that in diabetes, you can see consequences like white matter hyperintensities, even small infarcts. This is associated with that disease. And, other sorts of metabolic problems. Okay, so back to our question, what is the relationship of insulin resistance and type 2 diabetes to cognitive function and dementia? Well, I looked at this in terms of insulin resistance, and the Wisconsin Registry for Alzheimer's Prevention cohort at the Wisconsin Alzheimer's Disease Research Center. And I found that insulin resistance was related to worse cognitive decline in adults who didn't have dementia. And so what this figure is showing you, first of all, let me identify the parts of the figure. On this axis here, the x-axis, we have age. All right, so the age here was 58.8 years. So going up to 78.8 years. And then on this axis, we have cognition. And so you can see that there are declines across age and cognitive functioning. This is normal. I would like to say that this slope, it looks steep, but that's a function of the figure itself. The change over time is modest. It's not quite as steep as this is representing, to be honest. But what is interesting is that we do see an effect of insulin resistance. And so people who were insulin resistant, that's represented by the blue line here, they had worse cognitive decline than people who had normal or the best insulin sensitivity, which is represented by the green line. The difference was small. It's a modest effect, but interesting because this is a pretty healthy cohort. There were only, 6% who were diabetic, around 25% that had prediabetes. So the fact that we were able to see this difference speaks to the fact that insulin resistance is having a minor effect, but a measurable effect on cognitive functioning. And there are other studies that have found similar things, that insulin resistance has been associated with worse cognitive performance. There really aren't a lot of studies looking at insulin resistance and risk for Alzheimer's disease dementia. But I highlight one here that found, interestingly enough, in a sample of non-diabetic participants, that insulin resistance increased the risk or was related to an increased risk in a diagnosis of Alzheimer's disease dementia. The hazard ratio was 1.4, and that meant that the participants with higher insulin resistance were 40% more likely to develop AD dementia relative to participants with better insulin sensitivity. All right. And just, this is a brief slide here, but it says it all. I mean, type 2 diabetes is well recognized to be related to mild to moderate cognitive dysfunction. One thing, though, that deserves further investigation is looking at the extent to which duration and glycemic control affect diabetes and also the development of Alzheimer's disease dementia. But in this review of studies, they found that, of course, greater declines in cognitive functioning were shown to be related to longer duration of diabetes and worse glycemic control. So controlling one's diabetes is really vital for maintaining cognitive health. Diabetes has been related to an increased risk for dementia. So the relative risk for AD dementia has been found to be 1.4, at least in this one large study. It's a large review of studies that we call a meta-analysis. And then vascular dementia risk was 1.9, so a higher risk for vascular dementia. What do these risks mean? Well, a relative risk of 1.4 for AD dementia means that diabetics have 1.4 times or 40% increase in risk for AD dementia compared to non-diabetics. All right, so I'll stop here. That was a brief review of insulin resistance and diabetes and cognitive functioning and dementia.
Great. So we did have a couple chat questions come in. The first one is, what is the cause of insulin resistance?
All right. Well, that's an excellent question. And I think that an endocrinologist would probably be a better person to ask. But we do know that, people who are obese and overweight are generally insulin resistant. All right, so it could have something to do with, obesity and inflammation. Inflammation itself that could be relating to the cause of insulin resistance.
Great, thank you. And then this may be a similar one where this is maybe a question for the physician of the person wondering, but the question was, how could insulin resistance be improved?
Right. Yeah, I would suggest that diet and exercise is the best approach.
Great.
So, people, it's a complicated thing, in terms of the development of diabetes. It's an interaction of environment and so your behaviors, so, overeating and lack of exercise, but also there's genetic things that play a role too, to, make the pancreas less able to respond to the insulin resistance. But generally speaking, diet, exercise, maintaining a healthy weight, these are things that certainly losing weight could reverse your insulin resistance. You could return to normal insulin sensitivity.
Great, thank you. Does anyone else have any questions? Does anyone want to unmute yourself to ask a question?
I'm wanting to know if the insulin resistance is on that scale of on the A1C, where it would be 5.6, you are not pre-diabetic, but at 5.7, we all play with these numbers. Then you become pre-diabetic. The modifications of lifestyle and whatnot in the technical pre-diabetic phase.
Yeah, right. So if you have prediabetes, you likely have some insulin resistance. And like I had said, yes, anything you can do in terms of diet and exercise and losing weight, this will help. If you're overweight, if someone is overweight, then with the advice of their physician, they need to work together to lose that weight and hopefully, bring themselves back to normal insulin sensitivity. This may not always happen. It depends upon really exactly what's causing the insulin resistance.
Does that mean then that it would thwart the advancing of dementia, of Alzheimer's? Would it stop it or merely slow it, or?
Right. The effect of insulin, in my mind, the effect of insulin resistance in people who do not have diabetes is small. All right, in terms of the development of cognitive impairment. It's diabetes that's a more serious problem, but we do have treatments to control diabetes, and if somebody maintains good glucose control, they, they are at less risk, I would assume, for dementia. But I mean, really, what's really important, and I'll get to this at the end, exercise and maintaining a healthy weight is, it's not only good for your heart, it's good for your brain. So.
Thank you. Yeah. Does anyone else have any questions? Okay, I think we can continue on then.
Okay, so, well, this might become a little bit more complicated here, looking at the relationship of insulin resistance and diabetes to AD pathology and biomarkers of AD pathology. So let's review again. So what are these signs of AD pathology? So the amyloid plaques in the neurofibrillary tangles. And here are some actual pictures of tissue. So this shows you an amyloid plaque. And then here it's difficult to see, but the little purple lines here are neurofibrillary tangles within the neuron itself. Biomarkers are becoming increasingly important in Alzheimer's disease research and will become very important in the clinic at some point. But what are biomarkers? They are biological markers, measurable indicators of a biological process that can predict risk for or indicate the presence of disease. Biomarkers, there's tons of biomarkers in medicine. Fasting glucose would be, diagnostic for diabetes if it was greater than or equal to 126. Total cholesterol, HDL cholesterol ratio, this is commonly used as a marker for cardiovascular disease risk. And so we have similar sorts of things for Alzheimer's disease. They are being developed, okay? So there's not entirely the certainty yet with some of the markers in order for them to be used in the physician's office. But let's just review some of the types of biomarkers that we do have. So we've already mentioned amyloid PET and tau PET, so these would be imaging-based biomarkers. We have cerebral spinal fluid and plasma biomarkers. So we can measure the amyloid proteins in cerebral spinal fluid. We can measure tau proteins in that fluid. We can also measure those proteins in plasma. Amyloid PET and tau PET, these are they're very good. We have a lot of confidence that these are detecting amyloid and tau that's specific for AD. The plasma biomarkers are currently being developed and characterized. There's one plasma amyloid, there's one kind of plasma amyloid marker, and then both of these PET markers they're FDA approved, but they're not covered by Medicare. But you can purchase them out of pocket, but I assume, especially PET, is pretty expensive. But if you are enrolled in a clinical trial that uses amyloid PET, there is what's called there's Medicare coverage for that, and that's referred to as conditional Medicare coverage. Okay, but really, the plasma biomarkers, the field is very excited about these because eventually these will hopefully enter into the physician's office, and we can use this as a way to screen people to determine if they have these markers, and then that will give us a sense of knowing how much risk they carry for developing Alzheimer's disease. All right, so I'm here to talk about insulin resistance and diabetes and AD pathology, as well as biomarkers of AD pathology. There really aren't very many studies that have looked at insulin resistance and its relationship to AD pathology. And the studies are pretty mixed, honestly. Insulin resistance was related to amyloid plaques in one study, but not in another. All right. And then insulin resistance was not related to neurofibrillary tangles in 2 studies. So not very many studies, but they're suggesting that insulin resistance might not be related to these Alzheimer's disease pathologies. And then in the study that we did with the Wisconsin Registry of Alzheimer's prevention participants, we looked at the relationship between insulin resistance and markers of amyloid and tau in the cerebral spinal fluid. These are 2 different kinds of markers for amyloid. And what we found was that there wasn't a relationship between insulin resistance and these biomarkers of amyloid in the cerebral spinal fluid. So the graphs are showing you on the x-axis, this is age, and then on the y-axis, we have the measure of amyloid. And over time, there's a decrease in this one particular, this is the main amyloid marker. A decrease, I know it sounds like it's opposite of what you might expect, but in the cerebral spinal fluid, this marker has been found to decline over time in people who have amyloid that's building up in the brain. Now, we're not sure why that happens, but it could be because there's just not adequate clearance of amyloid from the brain. And so it doesn't end up in the cerebral spinal fluid. But it's commonly understood that this particular amyloid marker in the cerebral spinal fluid declines over time as amyloid builds up in the brain. So you see that there is a decline over time in our participants. I have to say this is primarily due to the participants where there is amyloid accumulating in the brain of some of the participants within the RAP cohort, but not all of them. So this negative slope here is due to that subsample of participants where we're seeing an increase of amyloid in their brain that we can detect by doing amyloid PET. And a similar thing here with this other kind of marker. It's a ratio actually between a tau protein and an amyloid protein. This one we would expect to increase over time in people who have amyloid that's accumulating in the brain. But you can see that the different lines really aren't like the slope of these lines are not different depending upon whether someone has good insulin sensitivity or has insulin resistance. And so since the lines are not any different, that tells us that really insulin resistance, at least in this study, wasn't related to biomarkers of amyloid, and it wasn't related to biomarkers of tau in the cerebral spinal fluid either. All right, so the same idea. The lines are really, the slopes of these lines are the same. And tau will increase in the cerebral spinal fluid of people who have amyloid and tau in their brain. Now, in terms of insulin resistance and amyloid and tau PET, so an imaging biomarker, again, there really aren't a lot of studies, and the results are mixed in terms of amyloid PET. With the RAP cohort, we did not find a relationship between insulin resistance and amyloid PET. And this is another study. This Fambasetti study was performed on the Baltimore longitudinal study of aging cohort. They didn't find a relationship between insulin resistance and amyloid PET. And then here's another study that actually did find a relationship between insulin resistance and amyloid PET. And then tau PET, I'm not aware of any published studies. I have looked at insulin resistance and tau PET and the RAP cohort as well as the Wisconsin ADRC cohort, and I don't see a relationship. I have looked at type 2 diabetes and tau PET too, and really I'm not finding a relationship there, although there is a signal that seems to indicate that if a diabetic has sufficient amyloid, if they have enough amyloid to be considered amyloid PET positive, then they have quite a bit of tau in their brain, and they have more tau than really than anyone, than non-diabetics and diabetics who are amyloid negative. But that this is a really preliminary finding, and it needs to be investigated further. But in general, I mean, when we're looking at diabetes and amyloid pathology, so amyloid plaques and tau, there's really no study. There's been several studies that have looked at this. And so a systematic review found that diabetes was not related to amyloid plaques or tau tangles. But it was related, diabetes was related to vascular disease in the brain. And just to emphasize, here are some quotes from that article. So they found a lack of an association between diabetes and AD-related neuropathology was consistent across studies, irrespective of the kind of methodology that they used to study the amyloid plaques and tau tangles. But in contrast, they found that diabetes was associated with increased large and small vessel disease. So, I mean, this wasn't really that surprising because diabetes is known to have adverse effects on the vessels. But it does emphasize the fact that people with diabetes have an increased risk for cerebrovascular disease, and that can develop into vascular cognitive impairment and dementia. So I know this leads to a contradiction. So there's a discrepancy here because we're finding from, studies that, IR and diabetes were related to an increased risk for AD dementia. And yet when we look at pathology, when we look at AD pathology in the brain, or we look at AD biomarkers, we're not finding a relationship between diabetes and those things. And so this is an issue. This is a discrepancy, and really we need research to try to explain this discrepancy. But one possible reason is because in the dementia risk studies, where they found a relationship between IR and diabetes and AD dementia risk, they're reliant upon mostly cognitive testing. And so vascular disease and AD, so cerebrovascular disease and AD can affect similar cognitive domains. So it's possible that some people with vascular dementia might have been misdiagnosed as having AD dementia in the dementia risk studies. It's possible, but I don't think it explains everything. Because, in the review of studies that looked at the relationship between diabetes and increased risk for AD dementia, they also controlled for cerebrovascular disease and cardiovascular disease. And when they controlled for that, they still found that diabetes was related to an increased risk for AD dementia. So misdiagnosis alone is not a complete explanation for this discrepancy that we find between the AD pathology and dementia risk studies. It is possible that the disease itself could have been less well controlled in the participants who were examined in the dementia risk studies. All right, so there could be a difference in the health of the samples that were looked at between these two kinds of studies. But we need to do more research really to understand the linkage between diabetes and insulin resistance to AD pathology. It's commonly thought that diabetes is related, of course, to AD dementia. And we are seeing that relationship, but we're not seeing as much evidence for a relationship between diabetes and the actual pathology in the brain. But again, this could have something to do with who is recruited to be in these samples. It could be that, these are, very healthy people that are donating their brains to be examined after their death. So in summary, insulin resistance and type 2 diabetes are related to cognitive dysfunction. This is pretty well established. I mean, it does increase one's risk for cognitive dysfunction. But like, I had mentioned, people are certainly wondering, what can I do to maintain cognitive health? And we'll get into that. But again, is diet and exercise. These are really important for brain health. Diabetes is related to increased risk for vascular dementia and increased vascular pathology in the brain. Diabetes and insulin resistance have been related to an increased risk for AD dementia, but have not been consistently related to AD pathology or biomarkers of AD pathology. So we just need to do more research to investigate this discrepancy and why type 2 diabetes and insulin resistance are associated with increased AD dementia risk. Future research, I think it's really important to look at diabetes duration and glycemic control, and to the extent to which these things play a role in the development of AD dementia. And then also diabetic treatment. There have been actually quite a number of clinical trials looking at diabetes treatments as a way to slow or prevent the development of the symptoms of AD dementia. I mean, honestly, thus far, they haven't found a drug that's able to do that, but there are still clinical trials taking place. Like there's one currently taking place with metformin, and that one is actually looking at metformin in non-diabetics to see if it has an effect on cognitive decline. And I have to say, this is so important. So much of our research is focused on European Americans and really highly educated European Americans. And this is really, it's just not just because, I mean, it's fine to investigate that group, but we need to expand beyond that group. Individuals from racial and ethnic groups that have been disproportionately affected by diabetes and dementia. So Black Americans, American Indians, Hispanic Americans are disproportionately affected by these diseases, but they've been underrepresented in research. So there needs to be a better effort to include these individuals. They really must be included in future research. So I can stop here if we have time for questions.
Yeah, so we did have another question come in here. That is, why or how are blood vessels in the brain damaged by diabetes or insulin resistance?
Okay, so I mean, that's a great question. So it affects the pliability. I mean, this is sort of outside of my wheelhouse, to be frank, but it affects the pliability of the vessel. It affects the blood flow. It can cause the vessels to become like diabetes, can cause atherosclerosis or the hardening of the blood vessels. And so it affects the blood flow. And in terms of like strokes, because there's atherosclerosis there, that increases the risk for clots to form. In terms of white matter hyperintensities, it's a little bit, I don't know that we quite understand why type 2 diabetes might cause white matter hyperintensities, to be frank. Another thing that happens in diabetes is that there's increased inflammation. And so the inflammation too has an effect on vascular function. I mean, and that could contribute to the formation of white matter hyperintensities.
Could it be also that we're looking at the wrong biomarkers?
So in terms of why, you mean the fact that we haven't found a relationship or not a clear relationship?
Yeah, I mean, if you're looking at certain biomarkers for dementia, and trying to tie it to diabetes, it's a known relationship between diabetes and dementia, but the biomarkers don't indicate it. So wouldn't that indicate that that the wrong biomarkers are being looked at?
Right. So, yeah, so diabetes is certainly related to vascular dementia. I think that's a clear-cut relationship. Now, it is thought to be related, and we do find that, in these population-based epidemiologic studies, that diabetes is related to an increased risk of AD dementia measured using mostly cognitive testing. Yeah, I mean, the sensitivity of the biomarkers to in terms of their representativeness or validity in representing the disease of AD is an important question. The CSF biomarkers and the PET biomarkers are really they're valid indicators, I think, of the disease process. So it is a bit of a curiosity. Also, we're not seeing a relationship between diabetes and AD pathology on autopsy. So I'm not saying that diabetes and insulin resistance isn't related to dementia. They are related to dementia. But it may not be through the AD pathway. But I can't say for sure that that's the case, honestly. I mean, because we just haven't done enough investigation. So yeah, I think the jury is still out on that question. And I say that because, I mean, there's a clear-cut relationship between IR and diabetes and AD, increased risk for AD dementia in these epidemiologic studies. But, when you look at reviews of several studies where they're not finding that pathology in the brain of diabetics, it does cause you to pause a bit. But that's why I'm saying we have to do more research, because there could be things like diabetic medications, could be that the people that are looked at in these autopsy studies had well-controlled diabetes, and maybe their diabetic medications were beneficial. I mean, this is something we're not sure about. I think I heard someone trying to ask a question.
Excellent, thank you so much. Any other questions at this point? Okay, I think we can continue.
Okay, well, honestly, I have pretty much talked about this. But so what can diabetics do to maintain good brain health? Obviously, talk to your physician about how to control glucose levels and blood pressure. That is one thing I actually haven't mentioned, is the blood pressure point, and we'll get to that, I think, in the next slide. Yes, so if you use insulin, you want to make sure that you control your blood sugar, but you don't want your blood sugar to go too low, because very low blood glucose can also cause cognitive decline. So that's something that's not, I don't know how much that's talked about, like in the clinic, but you don't want real low blood sugar. That's a problem too. All right, so yes, controlling systolic blood pressure is really important. There have been a couple of studies to indicate its importance to brain health. In this study, looking at diabetic patients, they compared intensive systolic blood pressure control to standard blood pressure control. And they found that the intensive blood pressure control did help reduce the progression of white matter hyperintensities. So I take note of these kinds of studies, because it's often that we don't see much effect of therapies on brain health. And here we are, with tight control of systolic blood pressure. This study shows that it's reducing the progression of white matter hyperintensities. There is also another study that has shown that tight blood pressure control reduces the incidence of mild cognitive impairment. Right, so this is a very, very important finding. All right, so, making sure that your blood pressure is controlled, working with your physician to control your blood pressure is vitally important for brain health. And exercise, is really, really important. I mean, for many reasons, your heart, your mental health, your brain health. And there have been a lot of studies, exercise, randomized controlled trials. We need more studies with diabetics, all right? So exercise, looking at the effect of exercise on cognitive functioning and diabetics. But these are the results from a review of randomized control, from a review of 36 randomized controlled trials looking at exercise as a treatment for cognitive functioning in adults over 50 years of age with and without mild cognitive impairment. So aerobic exercise and a combination of aerobic and muscle strengthening exercise was beneficial for cognition. Moderate and vigorous intensity both improve cognition. Moderate would be something like brisk walking. Vigorous is jogging. The vigorous exercise, though, was not more beneficial than moderate. So just, I don't think one needs to stress oneself out exercising. You need to exercise, but you don't need to, be too aggressive you need to do what's within your ability. Medium but not short or long duration was beneficial. Now I have to admit some of this stuff, like with the findings with vigorous exercise or the findings with long duration being, either of similar benefit as medium or moderate intensity exercise, it could be because people just have difficulty sticking to a long and vigorous exercise regimen. Interestingly, any frequency of exercise was shown to be beneficial. So basically, just getting out and doing something could be beneficial for cognitive functioning. And it improved cognition in people, exercise improved cognition in people with and without mild cognitive impairment. So that's a really encouraging finding, that even if someone has developed mild cognitive impairment, exercise could be a benefit and might slow the progression of the impairment into dementia. Does exercise reduce risk for dementia? There aren't very many studies looking at this, but I'm showing you one that was recently published, looking at daily step count and step intensity with incident dementia. And so the participants didn't have dementia at baseline. They were told to wear an accelerometer for 24 hours per day for 1 week. And so they were able to keep track. So this accelerometer kept track of their steps and the intensity of their stepping. And then the study investigators counted the number of participants who developed dementia during 6.9 years of follow-up. And what they found was walking 9,800 steps a day have dementia risk. So what they're showing you here on the on this y-axis here, this is the hazard ratio, so the risk for developing dementia, all cause dementia, right? So this is not just Alzheimer's disease, it's all types of dementia. And then here, this is the total steps per day. And so they're finding this little sweet spot at 9,800 steps per day reduces the risk of dementia. And then if you can't walk that many steps per day, they found that if you walked 112 steps per minute for 30 minutes, so if you engaged essentially, I guess, in brisk walking, that reduced risk by 60%. I mean, this study needs replication. It's an observational study. There is a risk of what we would call reverse causality, meaning that, as people develop dementia, they do tend to not engage in physical activity as much. All right, so there's not as much walking taking place. But interesting findings, and walking is, I just showed you a review of 36 studies that found that a moderate intensity exercise, brisk walking, was beneficial for cognitive functioning. I really like the WHO guidelines. You can find this on the web if you're not familiar with this already. It's a pamphlet and it details all sorts of strategies for risk reduction of cognitive decline and dementia. And it's evidence-based, and so they will indicate the quality of evidence that's being used for the particular recommendation. But unsurprisingly, the WHO recommends exercise, engaging in at least 150 minutes of moderate to intensity aerobic physical activity per week, also muscle strengthening activities. And if recommended amounts of physical activity can't be performed due to health conditions, people should be as physically active as abilities and conditions allow. So keep moving. Keep moving. That is the message. So in conclusion, for this presentation, I'll leave you with the summary of the WHO recommendations for the reduction in risk of cognitive decline and dementia. Obviously, engage in physical activity, stop using tobacco products, eat a Mediterranean-like diet, reduce alcohol consumption, and at midlife, lose weight if overweight or obese. So these are the main lifestyle modifications that can be done to help reduce the risk of cognitive decline and dementia. All right, well, thank you so much, and I'll be happy to answer more questions if you have them.
Yes, excellent. Thank you so much. This was really, really informative. Does anyone have any additional questions? I don't see any in the chat right now, but I think, Julie, did you just unmute?
Yes, I did. I'd
Great.
like to thank you, Dr. Ennis, for the presentation. Now, actually, I'm a nurse practitioner, so I've
Okay,
been
great.
for years for different things, but I heard about the metformin study, and I'm looking forward to the results from that. But I was thinking that, as diabetics, we're trying, the problem gets to be with all the fluctuations and the use of, the insulin being able to get to the cells, to get the glucose into the cells, causing, if you have the insulin resistance or even the diabetes, even in the brain, you're kind of not nurturing and getting the nutrients to the brain because you're not getting the glucose in there to work. And I think a lot of times there's so much fluctuation in our insulin levels to have that happen. So I think what we're finding in just general diabetic treatment is that if people can get on the pump and you can have less of a fluctuation, after meals, between meals, during the night, things like that, that your brain is able to function better and your body in general. And it also decreases all the long-standing sequela of the diabetes, like the eye problems and vascular problems and, the extremities and things like that. So, everything is affected by the diabetes and not being able to get the nutrients that it needs and the amount it needs. So have you seen any studies related to that recently?
I think that's fascinating. It's very difficult to study those daily fluctuations.
Right.
But I think that would be an important thing to look at because, in research, we have people come into the center and their blood is drawn. And so, that might be done once a year. Or we might assess diabetes through self-report. And this does not get at this question that you're raising about daily fluctuations. I mean, because I agree. There's fluctuations across the day, and those things could make a big difference.
Right.
And so having an insulin pump is, I guess, a resolution. I'm not sure it's a complete resolution, but I'm sure you know more about that than I do. But would make a difference. The brain is, so the brain doesn't rely as much on insulin to take in glucose.
Okay.
So people who have diabetes, glucose can get into their brain and it can get into their neurons. The major kind of, so it that happens. There are some neurons in the brain that are dependent upon insulin. So, I don't know. That's a good question. To what extent does diabetes influence those neurons? But,
Another comment was, obviously we know that one of the reasons why exercise also works with diabetics is because it does help work with the insulin to get insulin or the glucose into the muscles and things like
right,
that.
right,
right. Obviously, if we're using our brain,
the brain is different.
It's a different thing, a different
It
animal.
it is different. Because honestly, we're not quite sure if the insulin resistance that's in the periphery also exists in the brain.
And that's kind of what you're studying, looking
like. Yeah. So we're not sure if that's the case. I mean, there's some animal studies that suggest that that's the case.
Mm-hmm.
I mean, and some people suggest that insulin resistance starts in the brain and then goes to the periphery.
Right.
But we're not sure about that. But I do want you to understand that many of the nerve cells in the brain they're not dependent upon insulin for glucose to get into them.
Okay. So that may be why it doesn't matter.
But the brain is highly dependent upon glucose. And so that's why, these low glucose levels are not helpful.
Well, I'm actually being a geriatric NP. We don't like people to be too well controlled anyway, because that's where people end up getting too low, and then
they fall.
More people die from low blood sugars than from high blood sugars, and because they fall and they hit their heads, and then they cause traumatic injury to their brain.
Yeah.
But vascular and blood pressure are so important correlation with the diabetes too, I think.
It is. I think blood pressure is a really important thing to look at.
Mm-hmm.
Yes.
Thank you.
Thank you.
Thank you, Julie. That was great. I could listen to the two of you talk for a while. I think we all learned something there, so thanks for that. Were there any other questions? I see several kudos in the chat here, and yes, I echo them. People just saying this was very informative, and thank you so much for that information. Like I said, if you were someone who hopped on a little bit late, we will get a recording to you, but we really just want to say thank you so much to you, Dr. Ennis, for taking the time to spend with us today and share what you have learned and give all of us some talking points, so that I know there's some families, family caregivers, there's just interested community members, there's professionals on this call. So I know this is a question that either we have personally or that we are asked professionally. And so I hope that some questions that you had got answered today, and hopefully you have a hunger for more knowledge on this topic, because I think we learned about some great unanswered questions that really highlight the importance of research and of learning more. So thank you so much for your time, Dr. Ennis. We really appreciate it.
Well, thanks for inviting me. I've enjoyed talking with you. You had wonderful questions, and if you need further information, please feel free to reach out to me.
Thank you so much. Take care, everyone.
All right. Thank you.